Hi, my name is Ming Chawla, and this talk is called Furosemide Stress Testing in Acute Kidney Injury. First of all, let me just say that I'm very sorry that I will not be able to be joining you all in person. This is a trip I had very much been looking forward to, and I hope you'll enjoy this talk, even though it's being recorded and not live. So basically, this is a talk about how we try to develop a stress test. And I think that all of us from our medical training and certainly internal medicine training are very familiar with stress testing for the heart, particularly for acute coronary syndrome. So if a patient arrives to hospital and they have chest pain, we are all familiar with the differential diagnosis, and we're all familiar with the usual diagnostic tests that we utilize to try and ascertain if someone is having a heart attack or ACS. Now, one of the things that we also know is that if a patient has some questionable findings or doesn't have diagnostic tests either clear or rule out ACS or sufficiently rule in, we will often use some form of a stress test to try and confirm the presence or absence of more severe disease. And, we're very familiar with this. How do we detect if there is a critical lesion? And the way we typically do this is with either a treadmill test or some sort of inotrope like dobutamine and some sort of monitoring, either be radiology or echocardiography or something like this. And we have a really solid algorithm that involves taking a history and a physical, ECG testing, troponin, other types of diagnostics. And if we do not get a sufficient answer, we then move to one of these stress tests. And so, we thought to ourselves, most AKI, certainly not all AKI, but most AKI involves some form of tubular injury. And so we thought to ourselves, is there a way in which we can ascertain the severity of kidney injury by interrogating the tubule? And the preclinical data and certainly data in humans, even though not all patients have acute tubular necrosis, certainly the vast majority of acute kidney injury does involve some tubular injury. And so the idea is, can we find a way to interrogate the tubule, and can we try and understand if the tubule has been injured, and will that in turn be able to give us more information than a regular diagnostic? And the areas of the kidney that we're most interested in, of course, are the S1, S2, and S3 segment. We know that the S3 segment in particular in animal studies appears to be quite vulnerable to ischemic and reperfusion injury. We're also, of course, interested in the ascending limb. But really, this is where we think the action is, where we think the injury is occurring. This is the area we want to interrogate. And so we decided to do this by developing the furosemide-induced stress test. Now, furosemide has been available at the bedside for many, many decades, well over 50 years. And it has been studied very extensively in animal studies and in human studies. And so we really understand furosemide well. And as a consequence of this, furosemide has some properties that make it attractive as an agent to interrogate the tubule. The first of which is that furosemide is not filtered at the level of the glomerulus. In fact, furosemide is quite tightly bound to albumin. And in fact, patients who don't have albumin, patients who are analbuminic, and those folks actually exist, are quite resistant to the effects of furosemide. And furosemide must be actively secreted by the human organic anion transporter system, which sits here in the proximal segment of the tubule, and it's actively secreted. And so because of this becomes an interesting phenomenon, because now if you give furosemide to the patient, then we hypothesize that the ability to respond to furosemide in and of itself might be a nice way to test the integrity of the proximal tubule, because the proximal tubule is injured, it won't be able to move the furosemide across. Whereas if it's relatively intact, independent of the urine output, this might be a nice way to look at this. And so the hypothesis is quite simple, is the renal tubular integrity can be tested with a functional test, and the response, or lack of response, as measured by urine output, may indicate the severity of tubular injury before the baseline serum creatinine and urine output. And we, of course, know that serum creatinine is a late marker. And while urine output can be quite sensitive as a marker of acute kidney injury, it can also be quite nonspecific, which causes a series of problems. And so we developed this study wherein we looked at patients who had akin stage 1 or stage 2, and this is essentially the same as KDIGO stage 1 and 2. However, we did this before the KDIGO guidelines had been consensus certified. All the patients had to have a Foley catheter in place. And importantly, we really tried to focus on patients in whom were not pre-renal or post-renal. So anyone who we thought was obstructed was excluded. But more importantly, we insisted that there either be epithelial or granular cell cast in the sediment or a fractional excretion of 1%. Now, just to be clear, I'm not an enormous fan of FENA as a diagnostic, but this was just a way to try and really limit the study population to patients in whom would have met, the usual criteria for non-pre-renal and non-post-renal. And as I mentioned, we excluded patients who were actively bleeding, patients with profound CKD, and patients who had any obstruction. And the primary efficacy endpoint was progression to stage 3, so patients with stage 3 were obviously excluded. And so the primary efficacy outcome was, can we predict whether you progress on to stage 3 AKI within 14 days of FST? And we also looked at the composite of AKI and death in case there were some issues regarding censoring with this. This was published in 2013 in Critical Care Medicine. And what you see here, and the striped bars are the people who progressed to akin 3 and those who did not. And what you see here at all hours that we assessed, hours 1 through 6, there's a really stark differential in those patients who responded to the furosemide and those who did not in urine output in those patients who progressed as compared to those who did not progress. Now, one of the key things in the trial, which is in the methods, but I think it's very important to point out, is that we replaced the urine output with isotonic fluid, typically saline or lactated ringers, but typically saline. So it was very important for us not to create any harm by potentially creating a scenario where we were volume depleting the patient. Now, if the bedside clinician felt that the patient was volume overloaded, they had the option not to give all the volume back. But if they did not specify, all the urine output on an hourly basis that came out was replaced. So therefore, this is an isovolemic challenge of furosemide. And what we find is that the urine output over the first hour does pretty well. But once you reach 2 hours, you see this very nice discriminative capacity with an ROC curve of 0.87, and it slightly diminishes to around 0.85 over 2 to 6 hours. And just to refresh everyone's memory, an ROC curve is a way in which you grade how a diagnostic works. So an ideal diagnostic has an ROC curve value of 1, and one that is completely useless has a value of 0.5. So the tossing of a coin has an area under the curve of 0.5. And a perfect test that has the perfect ability to discriminate in a diagnostic form has a value of 1. And just to put it in context, troponin, which I think most of us would agree is a very good biomarker, lives in the neighborhood of around 0.91, 0.92. So 0.86, 0.87 is quite good, and certainly performs better than most AKI biomarkers. And this is the sensitivity and specificity. And what we found is that we really had the best combination at 2 hours of around 200 mLs. And it's also easier to remember. So if you give a standardized dose of furosemide, which is 1 milligram per kilogram if you're furosemide naive, and 1.5 milligrams per kilogram of furosemide if you have seen any loop diuretic in the previous 7 days, what you find is that if you are incapable of making 200 mLs of urine in 2 hours, you are likely to progress to stage 3 AKI. And if you are able to have a robust response, then in fact you do quite well. So we also took the time to measure biomarkers so we could compare the performance of the FST against other biomarkers. Now, to be completely honest, I did not expect the furosemide stress test to perform at this level. And what I had imagined we would do is we would use the biomarker in combination with the FST to get maximal performance. And I still think that's the way we ought to do this. And I'll show you some more data as the talk goes on about how I still think that's the right way to go. But in order to do a scientific apples-to-apples assessment, we measured, the usual well-established AKI biomarkers. And what we found here, and over here you can see all the biomarkers we measured, NGAL, IL-18, KIM-1, I7, T2, the combination, urine creatinine, fractional excretion of sodium, and the plasma NGAL. And what we find is the furosemide stress test outperforms all of them quite well. I want to point out, since it's here on the chart, look at the performance of FeNA. FeNA lives at the absolute bottom of the grading system. So the point here is that, not surprisingly and very much suiting my a priori assessment, the fractional excretion of urine is by and large a useless biomarker. I know that's not the classical teaching, but that's what the data show. And so if you then look at this for the inpatient receipt of RRT, the previous graph was just stage 3. This is now only for patients who are requiring some form of replacement therapy. You find that the performance of FST stays quite the same, and so does other biomarkers. They really don't improve very much. Now remember, these biomarkers were very much built to predict from pre-stage 2 and pre-stage 1 the onset of AKI. So I don't think that this is actually a very fair way to look at these biomarkers, because they were not built to do this. And when you look at NGAL or T2I7, what you find is that for the prediction of stage 2 AKI and for early AKI, they do extremely well. Remember, all these patients already have established stage 1 or stage 2 AKI. So the question we were asking is really quite different than wherein these other biomarkers have been utilized, which is how do they perform after AKI is established. So the key points here, I think, from this pilot trial were that the furosemide stress test is feasible, it's well tolerated, and as everyone knows, furosemide is very inexpensive, and giving back crystalloid, whether it be saline or lactated ringers, is also quite expensive. So this is a very nice way to interrogate a patient who already has acute kidney injury and attempt to assess whether they will progress or not. The performance of the FST, and I want you to notice this range of 0.82 to 0.87 because it continues to hold up, is really quite good performance. I think it's very important, and I hope that this message is received very clearly, that patients should be euvolemic before undertaking a furosemide challenge. Giving a substantial dose of furosemide to a patient who is hypovolemic, in my view, is quite irresponsible. And so we took a lot of time in this trial to make sure these patients were euvolemic. And I also think it's important that you be in the clinical setting where you have someone who is attentively assessing the urine output. Now, an indwelling catheter or a Foley catheter, I think, is an ideal circumstance, but I don't think it's absolutely mandatory. But I do think that you need to have someone or be in an environment, not necessarily in ICU, and if you're not in ICU, but a place where the nursing is sufficient wherein you can assess the hourly urine output for at least 6 hours. And so, we basically concluded that the furosemide stress test is a novel functional assessment of tubular function that has good predictive capacity for those patients that progress to advanced acute kidney injury. I really think that the risks are non-trivial in that even though we all have comfort with furosemide and it's easy to use, you really got to make sure that it's not your first-line diagnostic, and that you make sure the patients are appropriately resuscitated. I cannot stress that enough. And so, interestingly, in response to our paper published in Critical Care, Peter Vanderhoort's group and Peter Picker's basically wrote this letter back to Critical Care that was in part based on a study that they had done in Critical Care Medicine 2009, where they assessed the capacity of an intravenous furosemide dose to try and hasten the recovery of patients on hemofiltration. And so what they did is in the treatment arm, they gave 4 hours of furosemide versus placebo at 0.5 milligrams per kilogram per hour. So if you add that up, what you're basically getting is around 1.5 to 2 milligrams per kilo of furosemide, which is not so different from what we did. And what they found is even though furosemide did not hasten the recovery, so just to be clear, this was a negative trial, furosemide did not improve time to recovery. It did identify, it functioned very well as a diagnostic. Those patients who recovered had higher urine output, 654 mLs, versus 48 in those patients who eventually recovered. And this had a very statistically significant p-value with, notice, an RC curve around 0.84, which is very similar to what we showed in predicting severity. They showed that the opposite. It predicts severity in reverse, meaning who will recover, which we thought was a very interesting finding. And John and one of his former fellows, who's now an attending in Thailand, worked together, and they have recently published the furosemide stress test trial, the FST trial. And this was a trial wherein this investigator group utilized the furosemide stress test to try and enrich the population for early versus standard of care renal replacement therapy. So the idea is that let's remove all the patients who are destined to recovery with the furosemide stress test, which I think is really the correct way to use this test. I mean, this was largely the reason why I developed this test in the first place, was to enable a trial like this. And to see such a serious and thoughtful group put this together, I think is really impressive. And I hope that when you all have some time, you will take a look at this paper, because I think it's very beautifully done. And even though this study was a pilot trial and they did not show any difference between early versus standard of care FST, and it was a pilot trial to be fair, what they did do is they then were able to show you that they were able to take the patients out of the trial who were not destined to recover RRT. So what they did is they did the FST, and what you see is 44 patients were responsive, and so they were not randomized. And only 6 of them went on to clinically require renal replacement therapy. Now, this is really important because had you thrown these people into the mix, you would have really diluted your potential ability to show effect, because these people did not have sufficiently severe AKI, and they are unlikely to benefit from early renal replacement therapy because they in fact don't need it. So what you see here is the furosemide stress test in action in the confines of a randomized controlled trial. I think this was really beautifully done. So then they took the folks who are responsive, and then they randomized them to early versus standard of care. And what you find here is that the early versus the standard group for the non-responsive rate is quite similar in the number of people who end up getting renal replacement therapy. And not surprisingly, the early group gets more, which you'd expect because they're then randomized to an early intervention. But you see in the placebo arm, a lot of patients still required renal replacement therapy. And this is quite gratifying, because this is the goal, to make sure that in your control arm, it's still a group of people who have required renal replacement therapy, which they in fact did. And I already showed you this part, which is that the people who are responsive did not require very much. But I think the thing that was really interesting is they then looked at the performance of the furosemide stress test to predict the need for RRT. And what you find is this very similar AUC value of 0.83, which is in this range of 0.82 to 0.86, which we showed in our pilot trial. So in a large randomized controlled trial, John's group has been able to demonstrate that the FST holds up quite well. Now, this is a group from Japan, and Ket Doi worked with Robbie Starr at NIH for quite some time before he returned to Tokyo with E.C. Nori's group. And Royal Matsuura put together a similar kind of test, but this time they used it with plasma NGAL, not urinary, but plasma NGAL. And what you find here is the performance of the furosemide response, which is here in FR, was around 0.07, which is 87, which is very good. And it performed better than plasma NGAL, and it performed better than other urinary biomarkers for AKI and for the progression of AKI or death within a week. And these essentially are superimposable numbers. But I think what they did, which was very nice, is they then put it together into a decision tree. So using their data of an NGAL level of around 142 nanograms per ml. And if you look at the NGAL performance, the bottom measure, the area where you have the maximum sensitivity, is around 150. So this is very close to the standard cutoff used in many labs around the country. But they looked at it specifically based on their trial. And what they find is that if your NGAL is low, you actually don't progress to AKI. So you can use the biomarker to rule out acute kidney injury. Now, if it's above 142, then you say to yourself, well, okay, I now have an elevated NGAL, but we know that NGAL, it does not perform perfectly. Let me now test you. So this is sort of a person with a mildly positive troponin. Now let's go on and stress test you, right? And then when you get stress tested, what you find is that if you respond, you do just fine. If you don't respond, you progress to severe AKI. And this is exactly the way I think we should use the furosemide stress test. You should use a biomarker first, whether in acute coronary syndrome, that biomarker is typically troponin or an EKG. And if you have a finding which does not adequately discern the disease of interest, you then go to a stress test. And so I really think that the FST should not be a first-line test. I really think we should be utilizing our very low invasive biomarkers as our primary methodology for assessing this. And then you utilize the furosemide stress test to confirm your findings, because even though it's quite safe, it's not as safe as a biomarker. And I think that we should be using these in tandem. And I think that you'll get better efficacy and the ability to predict outcomes in this fashion. And colleagues of mine, Blahin McMahon, along with some others at Jay Coyner and others at Johns Hopkins University in Baltimore, Maryland, we basically looked at patients who had delayed graft function after an allograft. So these are all patients who were getting a new kidney that was being donated, and we then ascertained whether the standardized dose of 1 milligram per kilogram of furosemide intraoperatively and the commensurate response in urine output could help identify those people who are destined to get delayed graft function. And what you see here is very similar to what you'll see in all the FST data. Is there's a difference. People who do not have DGF have better urine outputs as opposed to those who do not. And this is for 2 hours over here. And if you look at 6 hours of urine output, you get better discrimination, which I think makes sense since these patients were assessed in the operating room. And then if you look at the absolute values, what you see here is the median values. You see this big difference, 952 versus 207 at hour 6. Similarly, for 2 hours, 250 versus 73. And what they found is that very similar, an ROC curve value of 0.5 if you had less than 600 cc's at 6 hours of urine output. And so, the summary of these data are as follows, is that functional kidney testing predicts the severity of AKI quite well. And I really want this point to be taken, is that it has synergy with AKI biomarkers. I know we have this sort of love affair with comparing A versus B, but that's not what we do in clinical medicine. We use these tools together. I really think that the Japanese data are a very good example of how you could use this. So whichever biomarker you have available, whether it be T2 and I7, which are a series of biomarkers which are approved in the U.S. and Europe to identify AKI. And I'm confident John will be talking to you guys a little bit about this during this week. But whether it's that or whether it's NGAL or whether it's some other biomarker that performs at a high level, I really believe that the biomarker, because of its low invasiveness, should be the first thing that we assess. And then if there's any question about that performance, or if you want to add confidence to a decision that you may make based on those data, that's where I think a furosemide stress test should be done. I do think that in a very austere environment, where creatinine tests aren't available, in certain parts of India, certain parts of Africa, that in a patient who is volume replete, and that can be clinically assessed, a furosemide stress test in that environment may be a good solo diagnostic, but that is really the only place I think I could imagine where that would be the case. I think that I've really been quite gratified to see that the FST, no matter what study or environment you put it in, has this very consistent performance level in the 0.82, 0.84 to 0.87 range, which is really quite good for an inexpensive test, which is available around the world. And so, in conclusion, FST is an inexpensive and safe test to assess for the severity of acute kidney injury. It has now been demonstrated in multiple cohorts, whether it's in a transplanted kidney, for severity, for recovery. It's been also done in pediatrics with some success. And so I think that this is something which we need to continue to work on, but I do think that there's sufficient signal that we can start utilizing the furosemide stress test in our routine practice, given its very nice safety profile, familiarity. And I think, just recognize that the idea for this really came from the observation that most of us, before we decide to dialyze someone, we usually just give them a big, chunk of furosemide or Bumex or butenamide, depending on where you are in the world. And we know that if you give someone a really large dose of furosemide, nothing happens to their urine output. You got to put them on dialysis. And so I think this is just taking an observation, which is at least 50 or 60 years old, that failure to respond to furosemide means you're going to have severe AKI. I think that all that we have done is put a standardization around it and put some cutoffs, which is this 2 hours and 200 cc's or 6 hours and 600 cc's. I think largely which time cutoff you select should be based on what you're able to do at the bedside. I think in some environments, if you're in the ICU and you want to know the answer quickly, the 2 hour cutoff makes the most sense. I think if you're on the floor or an environment where you don't have the ability to be checking the urine, that frequently or hourly, 6 hours is probably okay. I do want to remind everyone, though, however, that some patients can really have a robust urine output, and someone needs to be watching just to make sure that they're not getting volume depleted. And you should, unless you're trying to take the volume off, replace that volume. And with that, I'll stop, and I'd be very happy to take questions. Thank you.